Good morning, sir.
Good morning. Good morning. Good morning. See, in the I'll just try. I'll share the screen with you.
Okay.
See, in last two clinics, I was talking about this head posture and all. So I have got a presentation in which I can show you some slides. So this abnormal head posture, as I told you already, is because of adaptation to strabismus. Basically, the children or any patient wants to avoid diplopia, and for that reason, the head is turned into the direction of the action of weak muscles, so that the eyes move in the opposite direction, and the patient will not have diplopia. So, what does abnormal head posture comprise of? There may be face turn. For example, in left lateral rectus palsy, the face will be turned to the left because then the eye will be towards right, and then the patient will not have diplopia. Then this is the example of face tilt. If you see this slide, there is a right face turn because there is right lateral rectus palsy, so this right eye is not able to move towards right side. So what the patient has done, the patient has turned the face towards right side so that the eye is moved medially, that is opposite numb, and that's why there is no diplopia. So this is an example of face turn. Yeah. Then say in oblique pulses there will be head tilt. Matlab, you can see that there is not only the face turn but the head is tilted. The head is tilted towards right. So in left superior oblique palsy, the head is tilted towards right, and there is a chin depression also, and the right face also is turned. And this is because of the chin. There is a superior rectus palsy, and in patients with congenital ptosis also, the chin gets elevated. So this is because of the child has elevated his chin to see clearly. So these are some of the examples of facial asymmetry, right? So this squint assessment is beyond the scope of these clinics. So I'm not discussing the squint assessment. Then ocular movements. I told you that there are various types of ocular movements, uniocular and binocular. But what we are interested in is only binocular movement. That is called as version. So how do you see the version? So these are the 6 cardinal positions of gaze. Last lecture I told you that the basically we want the both eyes to move to the we want the patient to follow the target towards right. So that is called as dextroversion. And then right and up, that is dextro elevation. Then right and left, that is dextro depression. Similarly, levo version means left towards left, the movement towards left, and levo elevation and levo depression. So this is how you see the extraocular movements, right? Yeah. In this slide, it is very clear. Say this is the both eyes are moved towards right and up. So this is dextro elevation. Then this is levo version, means the eyes move towards left. This is dextro, means towards right version, and this is levo depression. This is dextro depression, and this is again levo depression. So this is how you can check the extraocular movements, right? So Sometimes the patient will come with, say, injury to the orbit, like in the road traffic accidents or when there is a fall, then the superior orbital margin may be affected. So in that situation, we have to just palpate the superior orbital margin and we have to look for these points like tenderness, irregularity, and crepitus. So then we can look for the eyebrows and eyelashes. I told you about, the eyelashes. So these are some of the abnormalities of eyelashes that leads maybe edematous, maybe because of allergy or sty or insect bite or any inflammation of the eye. The eyelid may be edematous. And in case of systemic diseases like renal failure or cardiac failure, also the eyelids may be edematous. And there may be inflammations of the eyelids. So this is a slide. This slide, can you see this slide? Are you able to see the screen?
Yes, sir.
So you can see that the both eyelids are swollen. So this is a picture example of lid edema. So this lid edema can be because of conditions of the eye, like say insect bite or any allergy or any infection, or it could be if it is present in both eyes and if it is not associated with any ocular symptom, then it may be because of renal failure and cardiac failure. So this is how the lid edema looks like. Now the next slide is showing blepharitis. So these are the eyelashes, and you please note that there are these white, blue, yellowish white structures at the margin of the eyelashes, at the root of the eyelashes. These are nothing but scaly flakes because of blepharitis, right? So this is a very common condition in which you see white structures or white scales at the root of eyelashes, and this is associated with the dandruff of the hair. So this is blepharitis. It is a very common condition. That's why, and the treatment is very simple. You can just ask the patient to maintain proper lid hygiene. Then in the next slide, you can see this is the lid margin. This is the anterior lid margin, and this is the posterior lid margin. So बीच में जो है that is called as intermarginal strip. And in this intermarginal strip, these meibomian glands open. So sometimes the meibomian glands get inflamed or infected, so their orifices become prominent. So this is called as meibomian pouting. Yeah. Then this slide shows a pus point here, and there is a localized swelling of the eyelid, and this indicates sty or external hodriolum. So this is actually acute infection of the gland of Zeiss, Zeiss, Zeiss. So this is external hodriolum. It is the pus point is the pus is the point. It is pointing outwards or externally. So that is called as external hodriolum. Whereas internal hodriolum, you can't see the pus point here. It is pointing inside towards the palpebral conjunctiva, and it is acute inflammation of the meibomian gland. So this is internal hodriolum. So the treatment of both is same. We have to ask the patient to do hot fermentation, and we can give systemic antibiotics if required. And this is the third picture, which this is also very common. This is called as chalazion. Chalazion is nothing but granulomatous inflammation of the meibomian gland. So what is the difference between chalazion and this internal hodriolum? In internal hodriolum, the whole lid is swollen. It appears red, so it is an acute inflammatory condition. The patient will have pain and tenderness, whereas here the patient will be absolutely asymptomatic. Only complaint will be of a swelling of the upper eyelid. So this is chalazion. These are some of the other abnormalities of lid, like trichiasis. I showed you that day also. This is trichiasis.
Sir,
And this is entropion. See, this is entropion, that is eversion of the eyelid and lashes. So this is entropion, and this is ectropion. This is outward turning of the lid margin, and this is entropion, where the lid margins are turned inwards. So inward rolling of the eyelids. So these are pretty common things: ectropion, entropion, and this is called as symblepharon. This is an interesting condition. It is a sequelae of chemical injuries to the eye, in which there will be adhesions between the fornical conjunctiva and the limbus. So this is called as symblepharon. Okay.
sir,
Yeah. Tell me.
Sir, in internal hall
Yeah,
hordeolium
tell me, tell
में
me.
हाँ, so the red color is compulsory every time.
कंपलसरी नहीं होता है रेड कलर. समझ गया ना.
Sir,
पेशेंट को
तो
सिम्टोमेटोलॉजी देख लो ना. दे पेशेंट विल कंप्लेन ऑफ स्वेलिंग सिंस 2 or 3 days and there will be pain. Sometimes it may appear red, but there will be slight tenderness on pressing. So there are these 6 signs of inflammation may not be present in all patients, rubar, pala, dollar and all. But red color is not compulsory, but there will be slight diffuse edema of the eyelid around the hordeolum. Here you see, here absolutely the rest of the eyelid is absolutely normal, and only there is localized swelling, and it doesn't appear tender.
sir, so in edema of eyelid there is no pain.
If the in edema of eyelid, if it is because of say insect bite, there will be no pain. It depends upon the pathology, but if it is because of the sty, there will be pain. If it is
Okay,
because
so
of renal failure, there will be no pain.
okay, sir.
Have you understood?
Yes, sir.
See, it depends upon the pathology of the, lids. Why
Sir,
the
so here we have to perform eversion of eyelid now to see whether
इसमें
it is due to sty or not.
इसमें इवर्जन करना है आपको.
ये internal hordeolum में.
नहीं यार. सी इंटरनल ऑडियो में इवर्जन क्यों करेंगे आप. सी इवर्जन कब करना है, व्हेन यू आर सस्पेक्टिंग फॉरेन बॉडीज इन द आईलिड. समझ गए ना. So this patient will have severe pain, moderate pain होगा. तो if you evert the eyelid, then he will not allow you lid eversion, and you will not get anything. You will not gain anything by everting the eyelid. At the most, you can see the pus point, right?
Okay, sir. Yes, sir.
Only when you suspect foreign bodies, and if you want to see the palpebral conjunctiva, if you want to see whether there are any papillae and follicles, you do eversion of the eyelid. But this patient will have pain, so you don't perform eversion in this patient. In this patient, yes, you can perform eversion. So this is the drooping of the left eyelid, so it is called as ptosis. So you see, the upper eyelid is covering almost upper 2 mm of cornea here. You can't see the limbus in the right eye. Okay, so this is the normal position of the lid, and here it is covering excess of the cornea. It is almost covering half of the cornea, the upper eyelid. So it is ptosis. And what is legophthalmos basically? Legophthalmos is a very important condition because it is seen in facial nerve palsy, and facial nerve palsy is a very common condition. So because the facial nerve is affected, the patient's the orbicularis oculi, the nerve supply to orbicularis oculi will be affected, and orbicularis oculi will be weak. So patient will not be able to close the eyes completely. So that is called as legophthalmos. So what is legophthalmos? Inability to close the eyes completely. And this legophthalmos, the danger of legophthalmos is that when the patient sleeps, then the eye may remain open and the cornea may get exposed, and this exposure may lead to infection or ulcer in the cornea. So that is called as exposure keratitis. So that's why legophthalmos is important. And in comatose patients also you see legophthalmos. So in comatose patients, we have to instruct the sister to tape the eyelids while sleeping. So that is important. और legophthalmos में हमको क्या करना है basically, we can give lubricant eye drops and ointments to keep the cornea moist, because cornea is exposed to the air and cornea becomes dry. But nature has given one phenomena called as Bell's phenomena. When we attempt to close the eyes, as you see here, the eye moves upwards. So it tries to protect the eye. So that is called as Bell's phenomena. So what is it? It is nothing but upward rolling of eyeball. That is called as Bell's phenomena. These are some of the other abnormalities that you can see in the eyelid. So these three things are rare, but this is very, very common. In say patients above 40, especially in female patients, you can notice this yellow deposits on the eyelids, and these are nothing but xanthelasma, and this is because of increased cholesterol levels. So it will not affect the eyes as such, but you can send the patient to a physician for ruling out hypercholesteremia. Okay, so this is xanthelasma. In old patients, sometimes you see that the eyelid becomes very loose and it is sort of overhanging. So this is called as dermatochalasis. So yeah. Now let us come to the conjunctiva. So lower fornix is exposed by retracting. Drawing is not the correct word. Retracting the lower eyelid down while the patient looks up, and upper palpebral conjunctiva is exposed by everting the upper eyelid. Yeah. So you please see that I have already demonstrated the video. I want to explain it again. So a probe. Probe means a very thin blunt object like say a swab stick or a cotton bud, which is placed along the skin of the upper eyelid at the upper border of tarsus. मतलब पेशेंट को नीचे देखने के लिए बोलना है. पेशेंट शुड लुक डाउन and you place the probe at the upper border of tarsus. So how to locate the upper border of tarsus? If you see your own eyelid, there will be a crease, a line on the upper eyelid. So this lid crease is the mark of this upper border of tarsus. So along this lid crease you have to place the probe, and then eyelashes are grasped between index finger and thumb. We have to pull the upper eyelid, the lid margin, by grasping the eyelashes between index finger and thumb, drawing the lid away from the globe, and then the lid is rotated in vertical direction around the probe. And this is how you do eversion of the upper eyelid. So this is very important, and you should be able to perform the eversion of eyelid, because a lot of times foreign bodies are lodged in the palpebral conjunctiva, which you need to remove. And double eversion. So to view the upper fornix, you can do double eversion, and double eversion is done with the help of the lid retractor. Okay. Again, the same thing. Cotton tip applicator is placed at the lid margin, and patient is asked to look down and evert the lid. And this is double eversion. So notice that this is nothing but retractor over the anterior lid surface. We have to retract the anterior lid. So these are some of the conjunctival abnormalities. I told you that day that this is conjunctival congestion. Please notice that the limbus is relatively wide, whereas the congestion is predominantly in the peripheral area. And in this ciliary congestion, the congestion is more at the limbus. So that's why it is ciliary congestion. I told you to look for papillae. So this is how papillae look like. This is called as cobblestone appearance, in which you can see. How do you see papillae? This papillae will be nothing but they will be raised above the surface and of the conjunctiva, and this is follicle. So follicle will be like yellowish in color, and which are like nodular and which are surrounded by pale areas. So remember, these follicles are hallmark of trachoma, and papillae are seen in allergies. So these are the two abnormalities of conjunctiva that we commonly see. Sometimes you can see these cysts and concretions also. Yeah. Now let us come to sclera. Not much in sclera actually. Sometimes you see that there is a localized swelling at the sclera, and this is usually because of inflammation of the episcleral tissue. There is a tissue on the top of sclera, in the anterior part of sclera, that is called as episclera. So this episcleritis or inflammation of episclera is pretty common condition. It is benign. Patient will not have much pain. Patient will have just redness and nodule at the limbus, and patient will be relatively asymptomatic. But this scleritis is, friends, is very painful. Patient will have severe pain in the eyes, and you can see that there is a thinning of sclera here. You can see that this area appears bluish in color, and there is a thinning of sclera here, and rest of the sclera is inflamed. And this inflammation, you can see, if you see carefully, the conjunctiva is transparent, and it appears to be not involved, and the inflammation or the congestion is deep. So this is scleritis, and this scleritis is present in various autoimmune diseases like rheumatoid arthritis. Okay. So This is about sclera. Then about cornea, so this is called as placido-keratoscopic disc. This is used to see the surface of cornea. And if you want to, sometimes if you want to see, if you are in doubt whether the epithelium is intact, the corneal epithelium is intact or it is not intact, then you can put a fluorescent dye in patient's eyes and see the patient on slit lamp. So the deepithelialized area means where the area where the corneal epithelium is not present, like in corneal abrasion or corneal ulcer, it will be stained brilliant green with the fluorescent dye. So what you do is, सो दिस इज अ नॉर्मल फोटोग्राफ. इसमें अपने को सेंटर में एक ऐसा ओपेसिटी दिख रहा है and the rest of the things is congestion. Probably this is a case of corneal ulcer. So you want to know the extent of corneal ulcer. So what you do is you put fluorescent strip. एक ऐसा strip आता है fluorescent color का, तो we put that strip in the patient's eyes, ask the patient to blink and examine the patient on slit lamp. और slit lamp में भी एक cobalt blue filter आता है. You see, this is a blue light. So in that cobalt blue filter, you see the patient, examine the patient. So the area of cornea which is devoid of epithelium will be stained green. So this is called as fluorescent dye. These are some of the abnormalities of cornea that can be best seen by slit lamp examination. This is there, you can see that there are multiple white dots on the corneal surface, and this is because of inflammation of cornea. This is called as superficial punctate keratitis. Friends, this is a very common condition. Conjunctivitis जब होता है, usually conjunctivitis is because of virus, adenovirus, and this adenovirus usually causes this SPKs or superficial punctate keratitis along with conjunctivitis. Usually it heals on its own, but it is there. So this is superficial punctate keratitis, and these keratic precipitates are nothing but they are collection of blood cells at the back surface of cornea. You can see I was talking about the slit of cornea. So this is a slit of cornea. This is the anterior surface and this is the posterior surface. So on the posterior surface you can see white dots, and these white dots are nothing but keratic precipitates. And sometimes these white dots are not small. Here they are very small dot like, but here they are very big. So they are called as mutton fat keratic precipitates. And these keratic precipitates are usually seen in patients with uveitis. Yeah, in patients with chronic keratitis, cornea is normally a vascular structure. Cornea में blood vessel नहीं होते. The blood vessels usually end at the limbus. But in this photograph, you can see the blood vessel is coming right up to the center of the cornea. So this is because of corneal vascularization. And this corneal vascularization is seen in many conditions like viral keratitis and all. So this is how you check the corneal sensation. So this is a wisp of cotton. मतलब cotton को roll करना है और जो end है उसका, that end has to be very thin, and you just ask the patient to look straight and touch at the, notice where the patient it is touched, not at the center, at the periphery of the cornea, and the patient should blink. So this is how you check the corneal sensitivity. So this corneal sensitivity, why do you want to check? You want to check because of this condition, that is herpes keratitis. Many a times we are in doubt whether this corneal ulcer is because of virus or bacteria or fungus. So in herpes keratitis, the corneal sensation will be grossly diminished. So that's why we want to check corneal sensitivity. So what happens that there will be a brisk reflex closure of the eyes when we touch the cornea. So this is called this is how you check the corneal sensitivity. So then corneal curvature, which we can measure by keratometer, and this corneal curvature measurement is important in calculation of IOL power. And corneal thickness is measured by an instrument called as pachymetry. Yeah. Any doubts till now, friends? Are you able to understand? Are you able to understand? Any doubts? Any doubts, friends?
No, sir.
Okay. So up till now we have covered till cornea. So cornea के आगे क्या है? Anterior chamber. And what we want to see with the torch is something called as anterior chamber depth. So basically anterior chamber is nothing but the space between cornea and iris. It's a eye is like a balloon, I mean sphere. It's a spherical thing, na. So cornea and iris के बीच में जो space है, that is called as anterior chamber. And this anterior chamber is a very small space. Around the anterior chamber depth is around 2.5 millimeter, and the anterior chamber consists of aqueous humor. So the anterior chamber is formed by aqueous humor. So how do we check the corneal anterior chamber depth? What we have to do is we have to focus a beam of light on the temporal limbus. टेम्पोरल लिम्बस, सी टेम्पोरल लिम्बस मतलब कहाँ, यहाँ डालने का लाइट, यहाँ या यहाँ कहीं भी डाल सकते. दिस इज दिस इज नेजल लिम्बस, दिस इज टेम्पोरल. सो यू पुट द लाइट हियर at the temporal limbus. Are you able to notice the cross which I am putting with my laptop? So this is the temporal limbus. So you shine a light here, and what you have to see is parallel to the iris surface. And in normal or deep anterior chamber, the beam will pass through directly, illuminating the opposite limbus. Now see here, normally क्या होता है, light हमने यहाँ डाला है, and the nasal part of limbus is also illuminated. Can you see the brightness here? Are you able to appreciate the brightness here?
Yes, sir.
So this is called as normal depth. The anterior chamber is normal in depth. तो अगर anterior chamber normal रहेगा तो light हमने यहाँ डाला है तो it will pass through the anterior chamber and it will go to the nasal part of limbus. So that means that the anterior chamber depth is normal. So in this patient, see, just compare this slide with this slide. So in this patient, this is temporal, this is right eye, this is left eye. So right eye में मैंने यहाँ डाला light तो nasal part is illuminated. But in the left eye, you see, I have put light here, but I can't see the nasal side. The nasal side of iris is in darkness. That is why, because the light is not able to pass from temporal part to the nasal part. So this is the condition called as shallow anterior chamber. So normal depth anterior chamber का 2.5 millimeter है. And if it is more than 2.5 millimeter, it will be called as deep anterior chamber. And if it is less than that, it is called as shallow anterior chamber. So अभी इतना कुछ इसमें क्यों देखने का है? Why we want to see anterior chamber depth? Because in patients with shallow anterior chamber, there is a risk of angle closure glaucoma, and in angle closure glaucoma also the anterior chamber is shallow. So that's why we want to check the anterior chamber depth. So what are the causes of shallow anterior chamber? The causes of shallow anterior chamber include hypermetropia. In patients with plus power, the anterior chamber is shallow. Then narrow angle or angle closure glaucoma. So these are the two causes of shallow anterior chamber. Whereas hypermetropia का opposite क्या है? Myopia. So in case of myopia, the anterior chamber will be deep. Then when we remove the lens, then the iris will fall back. Like in patients who have operated for cataract, like in aphakia or pseudophakia, the anterior chamber will be deep. So these are the causes of deep anterior chamber, that is myopia, aphakia and pseudophakia. And shallow anterior chamber causes are hypermetropia and angle closure glaucoma. So with the help of slit lamp, we can assess the angle of anterior chamber by assessing there is a ratio. This ratio is nothing but the ratio of anterior chamber depth and thickness of cornea. So if the anterior chamber depth is equal or less than 1/4 of thickness of cornea, then angle closure is possible. So this is called as von Erich method. Basically, von Erich method is used to assess whether the angle is occludable, matlab angle can close or angle is not occludable. So for that we have to put the patient on slit lamp, and we have to compare the thickness of cornea with the anterior chamber depth. So this is the von Erich's grading, and we are interested in this grade 1. This grade 1, the patients are at a risk of developing angle closure glaucoma. again the same thing. The antechamber depth is shallow in angle closure glaucoma. It is deeper in periphery than in center in iridocyclitis. And these are some of the other causes of change in antechamber. Normally, I told you that antechamber contains aqueous humor. It is like water. Okay, it is transparent fluid. But in case of uveitis or inflammation of the iris, you can see cells, white blood cells, or you can see proteins, that is flare in the anterior chamber. So these are the abnormalities of anterior chamber. That is, one is called as cells, that is seen in active uveitis, and flare, and this flare is also seen in active uveitis, and this is because of exudation of protein from the iris or ciliary vessels, and it makes the aqueous slightly opaque. And in hypopyon, there will be collection of pus in the anterior chamber. So what is hypopyon? Hypopyon is nothing but presence of pus in the anterior chamber, and it is seen in ulcers, corneal ulcers. And hyphema. Hyphema means collection of blood in anterior chamber, and this is seen in blunt trauma. So hyphema and hypopyon, I hope you understand. So you can see, can you see this white line? And this white, this entire white thing is nothing but hypopyon, that is pus in the anterior chamber. And it is very logical. If the patient is sitting upright, then you can see the hypopyon will settle down. But if we ask the patient to lie down, then the hypopyon will spread. So patient is sitting for 5 minutes, then you can see a level, nice level. This is the upper level of hypopyon. This is linear. This is a line, and beyond that, beneath that line, you can see the collection of lymphocytes. So this is hypopyon. Hypopyon is seen in patients with corneal ulcer, and hypopyon is also seen in patients with acute uveitis. So these are the causes of hypopyon. And notice, this is hyphema. Hyphema means collection of blood. So blood is red in color. So you can see a red structure present in the lower half of the anterior chamber. So this is hyphema. Yeah. Lastly, we'll see about iris today. So yeah. So notice this part. This is abnormality. This is normal iris. So if you see in each other's eyes, iris is nothing but it's like a diaphragm which is present, which can reduce its aperture or it can increase its aperture, like the diaphragm of camera, depending upon the illumination. So that is the function of iris. Suppose the patient, we are in dark condition, then it will dilate and it will allow more light to pass through the eyes. And if we are in say bright condition, then it will the pupil will constrict and the amount of light that passes through the retina will be less. So this is the function of iris. So what I want to tell you is that it's not a flat structure, friend. As a uniform, as a road structure, there will be bumps, there will be portholes on the iris, there will be bumps on the iris. So this is called as iris pattern. So what is iris pattern? Basically, iris pattern is nothing but presence of crypts. Crypts matlab depression. If you see that these are the depressions present, and elevations are also there. So these elevations will be called as collarettes, and these elevations will be like circumpupillary. Matlab ye parallel ho gaye pupil se, whereas these crypts will be perpendicular to the pupil. So these are called as, this is called as iris pattern. So what is iris pattern? Iris pattern is nothing but the appearance of iris because of the crypts, that is depression on the iris, and collarettes, that is elevation on the iris. So that is the normal iris pattern. But in patients with uveitis, the entire iris will be swollen because of the collection of water, and this iris pattern will be lost. So that is one abnormality of iris that I want to tell you. So a dull, ill-defined pattern or muddiness of iris is suggest iridocyclitis. And heterochromia, I don't know whether you are able to notice here or not, but this part of the iris is slightly bluish in color, and this part is brown in color. So this is called as heterochromia iridis, matlab difference in color of the iris. So heterochromia. And here you can see that the iris is white in color here. So this is because of the atrophy of the muscle of the iris, and this may be because of glaucoma. And these nodules which are seen on the iris surface, these brown nodules are a sign of neurofibromatosis. So these are called as leash nodule. So these are some of the abnormalities of iris that you see. And in case of uveitis, you can see that there are flat nodules at the pupillary margin, and these are called as Coppé's nodules, or at the periphery of iris, they are called as Basaka's nodules. So these are the types of nodules that are seen in iris. So these are the nodules, friends. You can see very clearly here at the pupillary margin. These nodules are because of these are called as Coppé's nodules, and they are seen in uveitis. And these are slightly in the periphery of the iris, so they are called as Basaka nodule. And in uveitis, what happens to the iris? That the iris becomes sticky in color, sticky in nature, and it sticks with the lens. Lens है iris के पीछे तो lens है, so that forms adhesions between iris and lens, and these adhesions are called as synechiae. So you can see that here you can see that superiorly एक tag है iris का that is attached to the lens. So this is called as posterior synechiae, and these are pigment of iris on the lens. Basically, here what has happened is patient has started on treatment and we have dilated the pupil. So these adhesions or these synechiae are broken, but what they have left? They have left their impression on the lens. So this is pigment on the lens which has been left. So, but here in superiorly we can see a small tag which is still attached to the lens. So this is called as posterior synechiae. Last. So we have to examine adhesions of adhesions. This adhesions may be to the anterior to the cornea or posterior to the lens. And this iridodonesis is nothing but tremulousness of iris, which is seen in patients with aphakia. So this is iridodonesis. So that's all about today, friends. Tomorrow, according to your timetable, there is one theory. I think there is a lecture from 2 to 3 in ophthalmology. So what I will do is, see, we'll start with the corneal ulcer, which is a pretty easy and important topic, which I can explain on the, in the online mode. So I have already posted the corneal ulcer video on my YouTube channel. So you please go through that video, bacterial corneal ulcer. You please go through that video, and I will give some 2 or 3 questions to answer. So you can answer these questions in the Google Classroom, and whosoever answers that question, I will mark them as present. Okay. And if there is any doubt, please ask me about that tomorrow's schedule. Yes. Yes. Any doubt?
No, sir.
So what I will do is I will put the link of that bacterial corneal ulcer on the WhatsApp group. Sneha, you circulate that link to everybody, and you all of you please watch that video. If there are any doubts, you can ask me, and then I will give an assignment based on that lecture, and I will share the Google Classroom code with you. So you have to complete that assignment. That will be a very short assignment, 2 or 3 questions, but that need to be completed. Okay, then only I will mark you present, right? Is it clear? Any doubts?
Yes, sir.
Okay. But you please share this with everybody, or maybe you can make a WhatsApp group of entire batch, your batch, not only a batch, but this will be for all batches. Okay, and we can take an interactive lecture also if required, right? So I will share the link and all with you today only. Okay. Okay. Thank you, friend. Any doubts till now? Are you able to understand? Are you able to understand what I am trying to teach you?
Yes, sir.
Yes, sir.
Okay. So we'll continue the same. Tomorrow also we'll take a class and iris or आगे का cover करेंगे pupil and lens. Okay. And this corneal ulcer is in the afternoon. Okay. 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 Thanks, friends.